I hope this webinar will be valuable for you. Let me kind of walk through what I hope to accomplish in the next 45, 50 minutes. I want to start with just from a big picture perspective. What's happening? What is the government trying to do with MACRA? What's the big picture view as we make this shift from fee-for-service to value-based reimbursement? And then we're going to start to look at from a more granular perspective, we're going to take a look at what in the world is an HCC code and why is that important to me? Why should I care? Some of you may have a lot of experience with that. For others, this may be brand new. That's okay. We're going to talk through that, and then we're going to look at the legislation and the two tracks that are created by MACRA, APM and MIPS. The majority of practices will be participating under MIPS, so we're going to look at that. What are the components? How does that score work? How does it impact your practice? How does it impact your physicians? And then we're going to dig into some of the details so that you can see what risk-adjusted coding is and how that impacts your MIPS scores, particularly your MIPS scores for cost and quality. So we're going to be talking about that and then looking at the big changes that are coming. I know most of you are familiar with the big diagnosis coding change that we had last year when we transitioned from ICD-9 to ICD-10. Well, we've got changes that are coming again. And so we're going to take a look at what those two changes are and how they'll impact your practice. And I'll try to share a couple of stories about how some of our clients who are already participating in ACOs or risk-adjusted agreements with commercial payers, how they are handling this, right? As I mentioned before, I'll leave time for questions and answers at the end. So if you have questions as we go, feel free to put those in the questions panel, and I'll try to address as many of those as possible. All right, so what is the government trying to do? What is Medicare's aim with this new legislation? If you look at it from a big picture, they're really trying to shift risk and take risk off of the payer and transfer that to patients and to physicians. So they're trying to shift that risk from Medicare onto patients, onto doctors, to try to get patients and doctors involved with accomplishing the triple aim of healthcare. And the triple aim of healthcare is better healthcare for lower cost and better patient experiences, right? Who can argue with that, right? That the devil's in the details. The way that we've seen this manifested already is, I'm sure, pretty similar to your health plans and your own businesses. We've seen that here as patients with higher premiums and higher deductibles. We seem to get that every year from our insurance plan. And that makes it difficult for patients, but it also makes it difficult for practices, right? The challenge of collecting your AR from patients is much, much more difficult than collecting from Medicare or commercial insurance company. So we've seen that risk shifting from the payer to the patients, but we also see risk shifting from the payer to the providers, because the payers want to pay for quality. They want to pay for value, right? Not just fee-for-service anymore. And that means we're looking at risk adjustment on behalf of our patient populations, right? It all sounds so simple. Medicare wants to start measuring and paying for quality. They want value out of the system. And doctors typically push back against that and say, you know, you really don't understand. It's not that simple. There are things that are outside of my control. Specifically, that my patients are sicker than most patients. My patients are sicker than the average patient. I'm treating people who really need some help. And that's why it's so difficult to measure cost. It's so difficult to measure quality. And the comeback from Medicare is fine. We will do risk adjustment, but you have to prove it. You have to prove it. And the preferred risk-adjusted methodology of our government is HCC coding. Some of you may be familiar with this. This may be brand new for others. Let me explain it just a little bit. HCC coding, or hierarchical condition categories, have been around for over 13 years now. It has been adjusted year over year. And what it's trying to do is measure patient acuity for risk-adjusted plans. Originally, this was for Medicare Advantage plans, so that you could measure how sick a patient population is and use that to predict future healthcare expenditures for that same population. Right? That's what it was used for originally. And now we've seen that risk-based adjustment spread to other areas in our industry. Yes, it's still used for the risk adjustment in Medicare Advantage plans, but it's also used for hospital value-based purchasing. Right? We see that used for in accountable care organizations. Right? We also see that in the exchange plans under the Affordable Care Act. What that means is this risk transfer payments. Basically, if Aetna, if their silver plan patients are much sicker, have a much higher acuity score than the Blue Cross patients, then Blue Cross is going to pay a transfer payment to Aetna. And they're using HCC coding to measure that patient acuity, to handle that risk adjustment. We also see commercial payers that are using HCC coding in their risk-adjusted plans, right? Let me launch our first poll question just to get a gauge for the audience on where you are in this process. Basically, we're asking, does your practice have any current risk-adjusted contracts with those commercial payers? Typically, what we see is about right around 20% of the people have experienced this already. They're typically large multi-specialty groups in large metropolitan areas where they've had payers that have come to them and approached them with having these risk-adjusted contracts. So just if you're not sure, you can vote for not sure, but click in your vote there, and we'll try to share those results at the end as well. So let me explain what HCC coding really means. I think it'll be helpful to see this as an example. The way that HCC scores are calculated is it's got two components. It's got a demographic component and a diagnosis-specific component. So it's demographics plus diagnoses equals your HCC score. The demographics component is pretty simple, pretty straightforward. You have age. Obviously, the older you are, the higher your expected healthcare expenditures will be. Gender is included, and also eligibility status. So did you age into Medicare or did you become disabled? Are you dual eligible, meaning you're also Medicaid eligible? Trying to use some of these eligibility statuses as a proxy for socioeconomic indicator, because we know that impacts the amount of health care that a particular patient consumes. So there's the demographic piece of HCC coding, and then there's also the diagnosis piece. So it is using the diagnosis codes from the past 12 months, using those to predict what the next 12 months expenses will be for that particular patient. So what they do is you get your HCC score, and that's used as a factor. You multiply your HCC score, right, times the average Medicare cost per beneficiary. Right now, it's just over $9,000. And that gives you the projected Medicare cost for that particular patient or that particular patient population. So the average HCC score is 1.0. If you have a higher HCC score, 1.3, that means generally that is a sicker patient. And the sicker the patient, the higher the projected Medicare expenses will be. So the higher the score, the sicker the patient, the higher the expenses. The lower the score, the lower the patient acuity, and the lower the projected expenses. That's what HCC is being used for today. Let me show you a quick example that might be helpful for you. We'll take a quick look at this. In the first column, what you see is a 76-year-old female who's dual eligible, and her demographic criteria without any diagnoses shows an HCC score of 0.593. right? So she is 41% of the average HCC score in the Medicare population. So you take that 0.593, multiply it times $9,050, and for a Medicare Advantage plan, they would receive $5,366 to care for that patient over the next 12 months. If they're able to manage expenses, if they're able to keep her healthy, right, they can make money on that. But if they don't control their costs, they take that downside risk as well. And so you can see as we move over to the middle column, and you add that diagnosis of diabetes without complications, her HCC score is higher, and the expected cost for that patient is higher. You can see what happens when you code also not just diabetes without complications, but you know that it's diabetic patient with complications that has vascular disease and congestive heart failure. You can see the HCC score is much higher, 1.81. Obviously, that makes a significant difference in the expected expenditures for that particular patient. That's what HCC scores are all about. Okay? Now, I'm going to back up and talk a little bit about MACRA, a little bit about MIPS, so that we can take a look at that and understand where HCC coding and risk adjustment come into play in the new program that's being rolled out January 1st. Okay, so MACRA was the legislation passed by Congress last spring. And the things that everybody liked about MACRA, number one was the permanent repeal of the sustainable growth rate, right? The 21% cut that was hanging over our heads that Congress would kick down the road periodically for 3 months at a time or 12 months at a time. That permanently went away in the new legislation that was passed by both houses of Congress and signed by the President. It also announced the sunset of some of these older programs that people thought were really headaches. Meaningful use, PQRS, the value-based modifier. You know, that was the good news. The bad news was that these programs were basically reformatted and given a new name and new acronyms, and now we have 2 tracks to MACRA, MIPS and APM. APM is alternate payment models. Those are really people that are participating in advanced ACOs. If you don't know which direction your practice will be heading in, you'll be participating in MIPS. If you're going to be going down the APM track, you already know that. Some people who try to go down the APM track will not be able to meet some of those requirements, and they'll be measured in MIPS as well. So most of the practices are going to be participating in MIPS, not APM. So let me give you a bit more detail on MIPS real quick. There are 4 different components to MIPS that are weighted differently, and you can see that changes a little bit over time. The 4 categories remain the same, but the weights change. So let me talk briefly about each of these. Advancing care information, clinical practice improvement activities, and then the big 2 are quality and resource use. Advancing care information is basically what's replaced meaningful use, but a lot of the requirements are not quite as strict as the meaningful use requirements. The first thing is it's not all or none. You can get partial credit here, which is good news for a lot of people on the attestation front. Number 2, CPOE is not a requirement in the current proposed rule for advancing care information. Basically, the requirements are you using a certified electronic health record? Do you have a HIPAA plan in place? And thirdly, are you able to share information with your EHR and another EHR? That's what they're looking for in advancing care information. The smallest category is clinical practice improvement activities, and there is essentially a menu of 90 choices that your practice can choose from. You can choose which ones are most applicable for your patients and which ones are most applicable for your practice. You don't have to do all of them. You get a lot of leeway and discretion there, but basically they're all about patient access. So do you have extended office hours? Do you have a patient portal? Things like that are included in those 90 different choices. Now the big two, quality and resource use, are always equal to 60% of your MIPS score. That's what the government is really after, is measuring quality and resource use. And resource use is really just their fancy word for cost. That's what they really care about, is delivering quality and doing that at a reasonable cost. Okay? So you will get scores in each of those areas, and then you will get a final MIPS score based on your performance. Okay, so it's kind of like going back to college. Your MIPS score will be anywhere from 0 to 100. Right? And we expect a wide distribution of practices. So in 2017 is the first MIPS measurement year. You will get a score from 0 to 100, and that's graded on a curve. That'll be compared to your peers. Okay? So Medicare is going to collect all of this data, and then they're going to set what is called a performance threshold. Right? And we don't know what that number is going to be. They don't know what that number is going to be yet. Right? But it will be somewhere in a number between 0 and 100. And what that performance threshold means is the people that have a score higher than the performance threshold will get a bonus. And the people who have a score lower than the performance threshold will get a penalty. All right? That adjustment, that bonus or penalty, will not be applied until 2019. Right? So you don't get that bonus or penalty until 2019, where it gets applied against your normal fee-for-service charges in 2019. Okay? So the positive adjustment would be maybe a 1% bonus on your Medicare fee-for-service reimbursement in 2019 based on your 2017 MIPS score. Now, the higher or lower your score is away from that performance threshold, the larger your adjustment. Right? So if you have for example, if you have a 0, which would be a really hard thing to do, but if you had a 0 on your MIPS score, you would have a minus 4% adjustment to your Medicare fee-for-service in 2019. Now here's the part that makes this really tricky, is that the total adjustments are revenue neutral. Total adjustments are revenue neutral to the federal government. And what that means is they're going to be taking those dollars from the poor performers and giving those dollars to the good performers. Right? Kind of a reverse Robin Hood situation. So the total dollar amount of the negative adjustment will equal to the total dollar amount of the positive adjustment. All right, now before you get too intimidated by that, let me give you a little bit of context for this, right? It is not 100% of your revenue at stake. If you take an average practice and try to do a pie chart of where their revenue is going to come from in 2019, assuming that their Medicare concentration is 31%, this is what it looks like. The blue is their fee-for-service revenue from commercial payers. The red is their fee-for-service revenue from Medicare. And the other colors, the orange, the purple, the aqua, the blue, the green, that is their MIPS adjustment based on their 2017 MIPS performance, right? So it's less than 1.5% of their total revenue. To give you a little bit of context there, hopefully that's helpful for you. Now, I don't think you can take this and translate it to mean we're not going to worry about this. We don't have to deal with MIPS at all, because there are a couple of things that are changing. When you fast forward a couple of years and look at that same pie chart, here's what happens. Number one, Medicare becomes a larger percentage of your total patient population. As a country, we are getting older. There are 10,000 new Americans that are eligible for for Medicare each day. Right? That baby boomer generation is reaching that eligibility age, number one. Number two, the maximum penalty under MIPS grows from -4% to -9%. And then here's the kicker, is that the majority of commercial payers want to move in that direction also. They are trying to shift their payment models so that they're based on cost and that they are based on quality rather than fee-for-service as well. And that means that we have lots of change ahead. We can't avoid it. We can't make it go away. And I know that everybody's tired. We've had lots of change already. But we've got more changes coming, particularly in the way that we handle diagnosis coding. Right? Think about what your revenue cycle process looks like. It's probably looked like this for the past 35 years. And that means that our doctors in a fee-for-service model are paid on their volume, on their productivity. They're paid for CPT codes, right? And all you need to do is have a diagnosis code that makes it medically necessary. That was true in ICD-9. That was true in ICD-10. And if you make a mistake there, it's easily corrected. You get a denied claim, you resubmit, and that process is over and done with within 30 days, right? Now, we had a big change last year. Remember the switch from ICD-9 to ICD-10? That was a big change. People called it the Y2K of healthcare. Everybody was worried that denials were going to skyrocket as a result of ICD-10. Medicare predicted that denials would double or triple because of ICD-10. And that didn't happen. Denials didn't increase at all. They stayed completely flat after October 1st. Why? Well, it was because of that grace period that Medicare offered, saying that they would not deny claims for lack of diagnosis specificity. They wouldn't make any adjustments to your PQRS or value-based modifier for lack of diagnosis specificity. But that grace period is expiring. And that's the first big change that we have coming. On October 1st, 2016, Medicare is expected to begin denying claims for lack of diagnosis specificity, and we expect that the private payers will follow suit. And that is a big risk for practices because the average unspecified rate across the country is over 30%. That means there's significant risk there. I don't have time to really talk through that today, but if you've got questions on that, if you'd like additional information or resources on that, let me know. We're happy to provide that. The white plume client average is over 3 times better than the national average. Our clients are right around a 10% unspecified rate rather than 30%. But what we're going to spend most of our focus on today is that second change. And that means our diagnosis coding is not going to be over and done with in 30 days. It's going to have a 2-year tail to it. It's going to be used for risk adjustment. It's going to be used to factor in the target scores under MIPS. And so our diagnosis coding is much, much more important than it ever has been before. That's the second change that we have coming on January 1st. Right? Your diagnosis coding in 2017 will matter more than it ever has been before. Right? And what that means is we have to get the right diagnosis coding to get our fee-for-service claims paid. That's how a practice continues to protect their cash flow. But our 2017 diagnosis coding is going to impact 2018 HCC scores. And that HCC score is going to be used to get the risk adjustment done correctly for your quality and resource use measurements under MIPS. So our diagnosis coding now has a 2-year tail to it, right? Now, let me show you, give you just another visual as to why we think that's so important. One of the frustrations when you talk to doctors about this is everybody thinks that their patients are sicker than everybody else's patients. And everybody knows that their patients are sicker than what Medicare and the other commercial payers think their patients actually look like. How can we be so far off in what our doctors think their patients look like and what the payer thinks that patient looks like? The difference is what you code. That's how you explain the gap between those 2 points of view. The difference is what you code. The doctor is actually right, but what you've coded doesn't show how sick that patient truly is. So what you code really, really matters. Right? Again, it matters for this year under your fee-for-service as the payers begin to crack down on unspecified codes. It matters for next year on your HCC scores for your particular patients, and it matters 2 years out as the MIPS begins to use risk-adjusted scores for quality measures and resource use. Right? And we haven't had to do this before. You know, let's look at a quick example. Suppose that you have 3 identical patients. They're absolutely identical. They all need total knee replacements for their left knee. For patient number 1, we code unspecified osteoarthritis of the unspecified knee in support of that procedure. To the payer, that patient looks relatively healthy. Okay. Patient number 2, we code primary osteoarthritis of the left knee and morbid obesity. They have a BMI greater than 40. To the payer, that patient looks much sicker. For patient number 3, not only do we code primary osteoarthritis of the left knee and morbid obesity, but that patient also has type 2 diabetes with polyneuropathy. For that patient, we have accurately reflected patient acuity, right? Most people are not doing this today. And the reason why is that it doesn't matter. Under our current fee-for-service model, you get paid the exact same way for each of those identical patients, even though you coded it a little bit differently. Now, in the 4th quarter of this year, when Medicare and the commercial payers start to crack down on this, that example number 1, you'll probably get a denial there and need to resubmit that with primary osteoarthritis of the left knee. But let's look at that from an HCC perspective. What's the HCC score for each of those identical patients? You can see that there's a big, big difference. Patient number 3 has over twice the HCC score of patient number 1. And when they start to make adjustments, right, of what they expect to pay for those 3 patients compared to the average Medicare patient, you can see patient number 1, they expect to spend $4,000 less than the average Medicare patient. Patient number 3, they expect to spend $2,600 more than the average Medicare patient. So that's a difference of over $6,000 between those 2 identical patients when the only difference is what you coded from a diagnosis perspective. But most people are not doing this today. Let me launch our second poll question real quick. And really what we're looking is, does your practice currently monitor HCC coding? Do you have somebody that's looking at that, that's paying attention to that? So just quicken your answer. If you're not sure, you can use the choice for not sure. Well, again, typically what we see here is it's around 20%. It's usually the same people that are participating in risk-adjusted contracts with commercial payers that are the ones that are tracking the HCC coding today. So if you're not doing this yet, if this is unfamiliar to you, you're not alone in that. All right. Now, I had to borrow this slide from a Blue Cross Blue Shield plan. Up in Michigan, they were doing some education for some of their physicians. And I just loved it. I thought it was just spot on. You know, you look at this, and you can almost hear some of your doctors saying these things. I don't want to do this. I don't want to pay attention to that. I'm not treating their diabetes. That's not what I do. I only care about CPT codes. You know, please, I've had so much change. I am burned out with government change. Please don't do anything else to me. I just want to take care of my patients. Right? Right? Absolutely. Absolutely. We need doctors taking care of patients. Right? We don't want to turn our doctors into coders. But why is it important to make sure that we accurately code these comorbidities? Well, it's important, number one, because we want to get our fee-for-service claims paid correctly. We have worked hard to deliver excellent patient care and to take care of our patients, and we want to be paid fairly for that. Absolutely. Number two, we want to accurately reflect what our patients look like, right? We are supplying both the commercial and government payers with mounds and mounds of data every day. And they are analyzing that data, and if we're not careful, they're going to use that against us. Right? It's very clear they are moving towards paying for cost and quality, measuring cost and quality. That's where they want to go. And if they're going to make those items risk adjusted, we need to make sure that we're getting that done correctly so that we are not being penalized on these measures because we're not coding our diagnoses out to the highest level. The other thing that they're trying to do, point number 4, is the Physicians Compare website that Medicare puts online. It's available to patients. You can Google and find it. And it tries to classify providers as high cost or average cost or low cost, and tries to classify providers as high quality, average quality, low quality. Nobody wants to be low quality and high cost, particularly when that's not true. Particularly when it's not true, it's only because you are not accurately showing how sick your patients are. Number 5, we know that the commercial payers are moving in this direction as well. Commercial payers are going to follow suit. They are going to move in this direction as well, and we need to be prepared. This is not just a Medicare initiative. Other payers are going to do the exact same thing. The last point, number 6, and I think this is critical. When you're negotiating contracts with payers today, they know this information. They know very, very well what that patient population looks like. And you need to know it also. You know, let's go back to our last example. Let's say that you have a practice that does 200 total knees a year for Blue Cross Blue Shield patients, and you only do 20 for United. So it comes up time for contract renewal, and Blue Cross wants a volume discount because you do 200 total knees a year, right? Wouldn't it be great to be able to respond to them and say, you know what, Blue Cross, your patients have an average acuity score 20% higher than my United patients. They're much more likely to have post-surgical complications. They take up more of our time. I can't give you a discount. I really should be charging you a premium. They know that information already. And we need to be prepared so that we can have that discussion and level the playing field with them during those negotiations, right? It's very important to make sure that we accurately code those comorbidities. And for the compliance folks that may have questions about this, this was a question that was asked to Medicare. You know, basically, if we're not actively treating the diabetes, if we're not actively treating the obesity, should we be coding that? So long as the fact that it's documented and that it was that condition existed at the time of the visit, you can code those chronic and ongoing conditions, those status conditions that are Z codes. I included the link here so that you can go look up those coding guidelines from Medicare if you wanted to go see that, okay? So we want to make sure that we're doing a good job of accurately reflecting what our patients look like. Because remember, under MIPS, your cost and quality scores are going to be compared to your peers, right? It reminds me of the story of two friends that were hiking in the woods. They come across a bear, right? And they take off running. You know, one friend starts to outrun the other and then stops to change into his running shoes. Right? As the other friend passes him, he looks at him and says, "You're crazy. You can't outrun a bear." Right? And of course, the punchline is, I don't have to outrun the bear. I just have to outrun you. Right? You're being compared to your peers. You do not have to be perfect at this. And there's obviously opportunity for improvement. You know, but you first have to know how your physicians are doing. So let me launch another quick poll question. And the question is, which of the following best describes the majority of your physicians? They never document any comorbidities? Do they rarely document comorbidities? Do they usually document comorbidities? Or do they usually document and code those comorbidities? Right? What we typically see, the results here often vary by specialty. Primary care physicians typically do better on this than specialists, but we want to make sure that the good news is most people are already documenting these comorbidities. If they're not coding them, they're at least documenting them, and that makes an easier path towards making some changes in the future. So thanks for answering these poll questions. Those are always helpful as we go forward. Okay, so let's look and see how practices are doing at this today, how doctors are doing at this today. We looked at some data, basically 9 million coded diagnoses, and tried to isolate the HCC value by diagnosis. So we're not looking at the demographics. There's not much you can do to change that. But we're looking at how the doctors do their coding. And what you see when you slice and dice this by specialty is obviously there are some specialties that are going to rise to the top. Right? Oncology, nephrology, endocrinology, cardiology. Those are going to have higher HCC scores by diagnosis. And the reason why is obviously if you have a cancer diagnosis, if you've got diabetes with several complications, right? You've got congestive heart failure, your expected healthcare expenses are going to be higher than the average patient. And then you see the primary care kind of nestled in there in the middle. Then you get to some of the other specialties towards the bottom. Now, remember, you're being compared to your peers. The pediatrician is not competing against the oncologist here, being compared to other pediatricians. Okay? So you really have to look at that within your specialty. So let's drill down for a second, since we've been talking about total knees. Let's look at several different orthopedic practices and how they do in their average HCC per diagnosis. So this is a group of 30 different orthopedic practices across the country, all working in the same specialty. We're looking at their diagnosis coding. And what you see is that the top performers, their average HCC per diagnosis is almost twice the average for their specialty. The poorest performers, their average HCC per diagnosis is half. That's a 4x difference between the bottom performers and the top performers. How do you explain that? Is it that those patients are that much sicker at practices 1 and 2 and 3 than they are at practices 28, 29, and 30? No. The difference is in what they code, how they code. Are they accurately capturing the comorbidities for those patient encounters? Let's drill down even deeper and look within a practice. Now we're going to look within this practice, a 30-doctor practice, orthopedic practice, so we're in the exact same town, operating out of the exact same practice, in the exact same specialty. and you see a 20 times difference between the top 2 providers and the bottom 2 providers. Do you see that? The difference here is how they code. The data that they're supplying to Medicare, to the commercial carriers, says that provider 1's patients are 20 times sicker than provider 30's patients. And that's just not true. We need to make sure that we are accurately coding. One of the questions that I get are, well, what are HCC codes? You know, here's a way to look at it that might be helpful. HCC codes are not a different code set than what we're using with ICD-10. The payers automatically crosswalk your diagnosis codes to those HCC categories. And those HCC categories have different weights. So you can see type 2 diabetes without complications has a lower HCC weight than type 2 diabetes with complications, in this case with hyperglycemia. Morbid obesity, E66.01, 6% of the population in the United States has a BMI greater than 40. Question is, are we coding that on our patients that have a BMI over 40? Right, so these are the top 10 most frequently used ICD-10 codes that carry HCC weight. It's helpful to take a look at that. Do your patients have these conditions? Are you documenting it? Are you coding it? Good place to start when you start trying to dig into this and say, how are we doing? What does my practice look like today? Let me give you just a couple of takeaways, and then I'll try to answer as many of the questions that I can. Diagnosis coding is going to be much more important in the future than it ever has been before. Right? We know we've got those 2 big changes coming up. The first one in October, when more specific diagnosis coding is required in order to prevent denied claims. The second one begins in January, but you can practice that today, making sure that we're accurately capturing and coding those comorbidities for accurate risk adjustment. Because we know getting that done correctly is going to be very important for our MIPS scores. It's going to impact what your targets are for the quality measures and resource use measures under the new MIPS program. Those measurements are going to be used to measure you against your peers. And we want to make sure that you're measured fairly, right? We want to make sure that we're accurately showing how sick your patients are. Certainly recommend leveraging any existing tools that you may have to do that, and you want to do it in a way that makes this easy for your doctors. Don't turn your doctors into coders, right? Let them take care of your patients, but you need their help, right? You can't put all of that work on your billing and coding teams, but if you can help equip them with some good tools to review and correct those types of missing data, you can be successful with that. That's what our clients who are doing, who are really making this work, are using tools to make it easy for their doctors and give their coding teams tools on the back end to identify errors and make those types of corrections. We can certainly help with that if you need that help. Let me launch our last poll question. This one you can multi-select. So it's really just what type of follow-up information would be helpful for you. So if you want a copy of the slides, if you want a link to the recorded version of the webinar, we are going to do another follow-up webinar that really gets into some of the details of how do we operationalize this, where do we go from here. Once we've done a little bit of education, now what do we do with this? So happy to invite you to that if you'd like it. If you'd like to get set up with a White Plume demo, kind of get some one-on-one attention, I can get you in touch with our sales team for that as well. So check as many of those as apply to you, and I'll make sure we get you the correct follow-up on that. So thank you again for your time. Let me remind you, there will be a short 4-question survey. It takes 30 seconds. That's invaluable to us. I really would appreciate it if you take the time to do that once you get finished, once you get wrapped up. Here, you'll get a reminder to it in the you'll get that in the follow-up email as well. But the fastest way to do it is right after the webinar ends. All right, so let me try to answer some of these Q&A that we had here. Where can you find your HCC scores? If you're looking for your HCC scores, sometimes people have seen that in their QR/UR reports. So that's one place that you can look for that. The Medicare website is pretty cryptic. They do have files out there that you can use to kind of measure your patient population. I think the best place to start, the easiest place to start, is using those top 10 HCC codes. Those are the most frequent across the country, so they're probably the most frequent in your patient base as well. That at least gives you a good place to start. So how commonly are we really seeing that, and how commonly are we actually capturing, coding, documenting, those particular HCC codes? I think that'd be a good place to start. Next question was, are there any HCC codes for behavioral health type diagnosis? Absolutely. Some of the depression codes have HCC weight. Obviously, that has an impact on future healthcare expenses for a patient or a patient population. So that's important as well. One person asked, do we need to put this on every single claim? From a technical perspective, the answer is no, you do not. So long as the diagnosis is on one claim for that patient for the past 12 months, that will count towards the patient HCC score. However, in practice, we have seen some groups who, what they do is they code it every time. The reason why they do that is because they don't want it to ever fall off that 12-month window, number one. And number two, it makes it easier for them just to make sure that they do it every time so that they don't have to remember, oh, I haven't done it in 12 months, I need to do it today. They find it's easier if they just do it every time. So I've seen people do it different ways, but the technical answer is no, you do not have to do it on every single encounter. So hopefully that's helpful for you. Yep, for those of you who are asking about slides, just if the poll question's closed, you want a copy of that, you can put that in the questions panel. If you've got that there, we'll make sure that we follow up with you on that as well. All right, I think those are all of the questions that are broadly applicable for everyone. Thank you for your time today. I hope that this has been helpful for you. Again, my name is Matthew Menendez. If there's anything that I can do to help you in the future, please don't hesitate to reach out and let me know. If you've got some experience with this and done this before, I'd love to hear about what you've done to be successful also.